a WikiVidi documentaries production. Don't forget to like and subscribe. Enjoy. Drowning. Drowning is defined as respiratory impairment from being in or under a liquid. It is further classified by outcome into death, ongoing health problems, and no ongoing health problems. Drowning itself is quick and silent, although it may be preceded by distress which is more visible. Generally, in the early stages of drowning, very little water enters the lungs. A small amount of water entering the trachea causes a muscular spasm that seals the airway and prevents the passage of both air and water until unconsciousness occurs. This means a person drowning is unable to shout or call for help or seek attention, as they cannot obtain enough air. The instinctive drowning response is the final set of autonomic reactions in the 20-60 seconds before sinking underwater, and, to the untrained eye, can look similar to calm, safe behavior. Lifeguards and other persons trained in rescue learn to recognize drowning people by watching for these movements. If the process is not interrupted, loss of consciousness due to hypoxia is followed rapidly by cardiac arrest. At this stage, the process is still usually reversible by prompt and effective rescue and first aid. Survival rates depend strongly on the duration of immersion. In 2013, there were about 1.7 million cases of drowning. Unintentional drowning is the third leading cause of unintentional injury resulting in death worldwide. In 2013, it was estimated to have resulted in 368,000 deaths, down from 545,000 deaths in 1990. Of these deaths, 82,000 occurred in children less than 5 years old. It accounts for 7% of all injury-related deaths, with 91% of these deaths occurring in low-income and middle-income countries. Drowning occurs more frequently in males and the young. The rate of drowning in populations around the world varies widely according to their access to water, the climate, and the national swimming culture. Signs and symptoms. Drowning is most often quick and unspectacular. Its media depictions as a loud, violent struggle have much more in common with distressed non-swimmers, who may well drown, but have not yet begun to do so. In particular, an asphyxiating person is seldom able to call for help. The instinctive drowning response covers many signs or behaviors associated with drowning or near drowning. Frank Peer, a lifeguard and researcher of rescue techniques and drowning, notes that drowning begins at the point a person is unable to keep their mouth above water. Inhalation of water takes place at a later stage. Most people demonstrating the instinctive drowning response do not show obvious prior evidence of distress. Cause. Approximately 90% of drownings take place in freshwater and 10% in seawater. Drownings in other fluids are rare, and often relate to industrial accidents. In New Zealand's early colonial history, so many settlers died while trying to cross rivers that drowning was known as the New Zealand death. People have drowned in as little as 30 millimeters of water lying face down. Children have drowned in baths, buckets and toilets. Inebriates or those under the influence of drugs have died in puddles. Drowning can also happen in ways that are less well known. Oxygen deprivation. A conscious person will hold his or her breath and will try to access air, often resulting in panic, including rapid body movement. This uses up more oxygen in the bloodstream and reduces the time to unconsciousness. The person can voluntarily hold his or her breath for some time, but the breathing reflex will increase until the person tries to breathe, even when submerged. The breathing reflex in the human body is weakly related to the amount of oxygen in the blood, but strongly related to the amount of carbon dioxide. During apnea, the oxygen in the body is used by the cells and excreted as carbon dioxide. Thus, the level of oxygen in the blood decreases, and the level of carbon dioxide increases. Increasing carbon dioxide levels lead to a stronger and stronger breathing reflex, up to the breath hold breakpoint, at which the person can no longer voluntarily hold his or her breath. This typically occurs at an arterial partial pressure of carbon dioxide of 55 mm Hg, but may differ significantly from individual to individual, and can be increased through training. The breath hold breakpoint can be suppressed or delayed either intentionally or unintentionally. Hyperventilation before any dive, deep or shallow, flushes out carbon dioxide in the blood, resulting in a dive commencing with an abnormally low carbon dioxide level. A potentially dangerous condition known as hypocapnia. The level of carbon dioxide in the blood after hyperventilation may then be insufficient to trigger the breathing reflex later in the dive, and a blackout may occur without warning and before the diver feels any urgent need to breathe. This can occur at any depth and is common in distance breath hold divers in swimming pools. Hyperventilation is often used by both deep and distance-free divers to flush out carbon dioxide from the lungs to suppress the breathing reflex for longer. It is important not to mistake this for an attempt to increase the body's oxygen store. The body at rest is fully oxygenated by normal breathing and cannot take on any more. Breath holding in water should always be supervised by a second person, as by hyperventilating, one increases the risk of shallow water blackout, because insufficient carbon dioxide levels in the blood fail to trigger the breathing reflex. A continued lack of oxygen in the brain, hypoxia, will quickly render a person unconscious, usually around a blood partial pressure of oxygen of 25–30 mm of mercury. An unconscious person rescued with an airway still sealed from laryngospasm stands a good chance of a full recovery. Artificial respiration is also much more effective without water in the lungs. At this point the person stands a good chance of recovery if attended to within minutes. More than 10% of drownings may involve laryngospasm, but the evidence suggests that it is not usually effective at preventing water from entering the trachea. The lack of water found in lungs during autopsy does not necessarily mean there was no water at the time of drowning, as small amounts of fresh water are readily absorbed into the bloodstream. Hypercarbia and hypoxia both contribute to laryngeal relaxation, after which the airway is effectively opened through the trachea. There is also bronchospasm and mucus production in the bronchi associated with laryngospasm, and these may prevent water entry at terminal relaxation. The hypoxemia and acidosis caused by asphyxia in drowning affect various organs. There can be central nervous system damage, cardiac arrhythmias, pulmonary injury, reperfusion injury, and multiple organ secondary injury with prolonged tissue hypoxia. A lack of oxygen or chemical changes in the lungs may cause the heart to stop beating. This cardiac arrest stops the flow of blood and thus stops the transport of oxygen to the brain. Cardiac arrest used to be the traditional point of death, but at this point there is still a chance of recovery. The brain cannot survive long without oxygen, and the continued lack of oxygen in the blood combined with the cardiac arrest will lead to the deterioration of brain cells, causing first brain damage and eventually brain death, from which recovery is generally considered impossible. The brain will die after approximately 6 minutes without oxygen at normal body temperature, but hypothermia of the central nervous system may prolong this. The extent of central nervous system injury to a large extent determines the survival and long-term consequences of drowning. In the case of children, most survivors are found within 2 minutes of immersion, and most fatalities are found after 10 minutes or more. Water aspiration. If water enters the airways of a conscious person, the person will try to cough up the water or swallow it, often inhaling more water involuntarily. When water enters the larynx or trachea, both conscious and unconscious persons experience laryngospasm, in which the vocal cords constrict, sealing the airway. This prevents water from entering the lungs. Because of this laryngospasm, in the initial phase of drowning, water generally enters the stomach and very little water enters the lungs. Though laryngospasm prevents water from entering the lungs, it also interferes with breathing. In most persons, the laryngospasm relaxes some time after unconsciousness, and water can then enter the lungs, causing a wet drowning. However, about 7–10% of people maintain this seal until cardiac arrest. This has been called dry drowning, as no water enters the lungs. In forensic pathology, water in the lungs indicates that the person was still alive at the point of submersion. Absence of water in the lungs may be either a dry drowning or indicates a death before submersion. Aspirated water that reaches the alveoli destroys the pulmonary surfactant, which causes pulmonary edema, and decreased lung compliance, which compromises oxygenation in affected parts of the lungs. This is associated with metabolic acidosis and secondary fluid and electrolyte shifts. During alveolar fluid exchange, Diatoms present in the water may pass through the alveolar wall into the capillaries to be carried to internal organs. Presence of these diatoms may be diagnostic of drowning. Fresh water is hypotonic and hyponatremic relative to blood, so causes osmotic diffusion of water into the blood and sodium to the alveoli, leading to hypovolemia and hemodilution with hemolysis. Hyponatremia and hypokalemia, the resulting elevation of plasma K+ level and depression of Na+ level, alter the electrical activity of the heart, which can cause ventricular fibrillation. In animal experiments, this effect was shown to be capable of causing cardiac arrest in 2 to 3 minutes. Acute renal failure can also result from hemoglobin from the burst blood cells accumulating in the kidneys, and cardiac arrest can also result if cold fresh water taken into the bloodstream sufficiently cools the heart. Sea water is hypertonic relative to blood, so water diffuses from blood into the water in the alveoli, and the electrolytes diffuse into the blood, leading to hypovolemia, hemoconcentration and hyponatremia. The laboratory blood tests may show these shifts, which may be diagnostically useful. In animal experiments, the thicker blood requires more work from the heart, leading to cardiac arrest in 8 to 10 minutes. Autopsies on drowned persons show no indications of these effects, and there appears to be little difference between drownings in salt water and fresh water. After death, rigor mortis will set in and remains for about 2 days, depending on many factors, including water temperature. Cold water immersion. Submerging the face in water cooler than about 21 degrees Celsius triggers the diving reflex, common to air-breathing vertebrates, especially marine mammals such as whales and seals. This reflex protects the body by putting it into energy-saving mode to maximize the time it can stay underwater. The strength of this reflex is greater in colder water, and has 3 principal effects. The reflex action is automatic and allows both a conscious and an unconscious person to survive longer without oxygen underwater than in a comparable situation on dry land. The exact mechanism for this effect has been debated, and may be a result of brain cooling similar to the protective effect seen in patients treated with deep hypothermia. The actual cause of death in cold or very cold water is usually lethal bodily reactions to increased heat loss and to freezing water, rather than any loss of core body temperature. Of those who die after plunging into freezing seas, around 20% die within 2 minutes from cold shock. Another 50% die within 15–30 minutes from cold incapacitation, and exhaustion and unconsciousness cause drowning, claiming the rest within a similar time. A notable example of this occurred during the sinking of the Titanic, in which most people who entered the sea water died within 15–30 minutes. Heat transfers very well into water, and body heat is therefore lost extremely quickly in water compared to air. Even in merely cool swimming waters around 70 F, a water temperature of 10 C can lead to death in as little as 1 hour, and water temperatures hovering at freezing can lead to death in as little as 15 minutes. This is because cold water can have other lethal effects on the body, so hypothermia is not usually a reason for drowning or the clinical cause of death for those who drown in cold water. Hypothermia present a risk for survivors of immersion, as for survivors of exposure. In particular, the risk increases if the survivor, feeling well again, tries to get up and move, not realizing their core body temperature is still very low and will take a long time to recover. Most victims of cold water drowning do not develop hypothermia quickly enough to decrease cerebral metabolism before ischemia and irreversible hypoxia occur. The neuroprotective effects appear to require water temperatures below about 5 degrees Celsius. Diagnosis. The World Health Organization in 2005 defined drowning as the process of experiencing respiratory impairment from submersion/immersion in liquid. This definition does not imply death, or even the necessity for medical treatment after removal of the cause, nor that any fluid enters the lungs. The WHO further recommended that outcomes should be classified as death, morbidity, and no morbidity. There was also consensus that the terms wet, dry, active, passive, silent, and secondary drowning should no longer be used. Experts differentiate between distress and drowning. Forensics. Forensic diagnosis of drowning is considered one of the most difficult in forensic medicine. External examination and autopsy findings are often non-specific, and the available laboratory tests are often inconclusive or controversial. The purpose of investigation is generally to distinguish whether the death was due to immersion, or whether the body was immersed post-mortem. The mechanism in acute drowning is hypoxemia and irreversible cerebral anoxia due to submersion in liquid. Drowning would be considered as a possible cause of death when the body was recovered from a body of water, or in close proximity to a fluid which could plausibly have caused drowning, or when found with the head immersed in a fluid. A medical diagnosis of death by drowning is generally made after other possible causes of death have been excluded by means of a complete autopsy and toxicology tests. Indications of drowning are seldom completely unambiguous, and may include bloody froth in the airway, water in the stomach, cerebral edema, and petrous or mastoid hemorrhage. Some evidence of immersion may be unrelated to the cause of death, and lacerations and abrasions may have occurred before or after immersion or death. Diatoms should normally never be present in human tissue unless water was aspirated, and their presence in tissues such as bone marrow suggests drowning. However, they are present in soil and the atmosphere, and samples may easily be contaminated. An absence of diatoms does not rule out drowning, as they are not always present in water. A match of diatom shells to those found in the water may provide supporting evidence of the place of death. Drowning in salt water can leave significantly different concentrations of sodium and chloride ions in the left and right chambers of the heart, but this will dissipate if the person survived for some time after the aspiration, or if CPR was attempted, and have been described in other causes of death. Most autopsy findings relate to asphyxia and are not specific to drowning. The signs of drowning are degraded by decomposition. Large amounts of froth will be present around the mouth and nostrils and in the upper and lower airways in freshly drowned bodies. The volume of froth is generally much greater in drowning than from other origins. Lung density may be higher than normal, but normal weights are possible after cardiac arrest reflex or vasovagal reflex. The lungs may be overinflated and waterlogged, filling the thoracic cavity, and the surface may have a marbled appearance, with darker areas associated with collapsed alveoli interspersed with paler aerated areas. Fluid trapped in the lower airways may block the passive collapse that is normal after death. Hemorrhagic bullae of emphysema may be found. These are related to rupture of alveolar walls. These signs, while suggestive of drowning, are not conclusive. Water safety. Most drowning is preventable. It has been estimated that more than 85% of drownings could have been prevented by supervision, training in water skills, technology, regulation and public education. Surveillance. Many pools and designated bathing areas either have lifeguards, a pool safety camera system for local or remote monitoring, or computer-aided drowning detection. However, bystanders play an important role in drowning detection and either intervention, or the notification of authorities by phone or alarm. The acronym RID was originated by Frank Peer to summarize important reasons why lifeguards may be unaware of a drowning. The term stands for failure to recognize the struggle, the intrusion of non-lifeguard duties upon lifeguards' primary task, preventive lifeguarding, and the distraction from surveillance duties. In his paper on the RID factors, Peer makes a number of observations on the role and the required behavior and training of lifeguards, as well as the importance of administrators directing lifeguards to this role and avoiding double-tasking them. He ended by summarizing the role of lifeguards as guardians of life, and that they should be directed exclusively to this duty and none other, while on surveillance, due to the high value placed on human life. Brought to you by WikiVidi documentaries. Would you like to know more?